Hi everyone, I am Dr. Ramesh from Cessna Lifeline Veterinary Hospital. Today we have a golden retriever, 1 year 6 months of age. He has got this big hygroma. We have tried treating it medically 3 times. We have removed the fluid. Once we have injected one steroid depamedrol inside, but still it's coming again and now it's started getting pain for the dog. So we are removing it. Can I get the pen? So what we are doing in this case, we are going to try to preserve extra skin from this area and make sure that we don't deal with the wound adhesions later on. So my incision will go from this area, from here and from this area. So this much skin we are removing, extra skin, but I am not removing too much skin right now. Sometimes we struggle for the suturing, and I am going to protect lots of subcutaneous tissue also. So I am just giving incision here. I am giving incision over the hygroma. And these hygromas are highly vascular area because there is a constant inflammation is there. Body react against these areas. So always we see lots of blood supply, a lot of blood supply. It bleeds a lot. So doing without cautery is almost very difficult to do this without cautery. So what I am doing now, I am just separating some of the subcutaneous tissue because I need to protect most of the subcutaneous tissue so that it makes a padding when I suture, and we can avoid damage to the skin during the healing process. So I am just taking a little extra tissue from here. So you can see this subcutaneous layer I am separating so that this will help me at the time of suturing. I am suturing it. So I will always try to protect it because this surgery looks very simple, but sometimes you need to deal with lots of complication for these surgeries. And being these are simple surgery, when you get more complication in the simple surgery, then you get more irritated also with that. So you have to go down slowly. You need to keep removing this all fibrous tissue. Just cutting the other side. In case at the time of suturing, if we see that the extra skin is there, we can cut later on rather than we are removing extra skin, and then at the end if we are not able to close it without tension, we struggle later on. This side also I am just taking care of this extra fibrous tissue layer. I am making sure I am separating it and keeping this fibrous tissue layer with me for the suturing. I'll try if I can remove this whole hygroma as such, but sometime I end up opening it at the end. So only at the Olecranon process only it is attached now. So this is the area where it may open up suddenly. Here I need to take some of the periosteal area to avoid it opening. I'm trying to make sure that all the membrane, secretory membrane I can remove as such. Some part of periosteum also I am removing with this little bit, so we are able to remove the whole bursa as such. And sometimes it can open up, but still you need to remove all the secretory tissue from this area. Now I can see that I'll able to close it very easily without any extra tension, so we can just close it nicely. I'll make sure that we don't deal with any small bleeders, because that can cause little dead tissue formation, and in 10% cases, despite of this big surgery, it can reoccur. So we already discussed with the client that there is 10% chance that this can reoccur in future, and it can reoccur even in other leg also. For the suturing, can I get 20 more? You can give me. No, keep it like this. So my aim is first to put lots of interrupted sutures with this subcutaneous tissue which I have separated. Can you see this subcutaneous tissue is there, which I separated, and I am going to suture it like this. Some area I am going to take a little bit of tissue from this area also, but this first suture I am putting directly, it's a mattress suture I am putting to make sure that the opposition is very good. You can see that. You can see this thick layer of the fibrous tissue always you need to protect when you are doing the dissection, because this can help to avoid recurrence chances in these cases. And I always first try these cases with the medical management before I advise to the client surgery, because if we are doing the surgery in first go, this fibrous tissue will be very less, and sometime I got problem more in those cases where I operated early stage. In old cases we don't get these problems, and they do well. In old cases they do well with the surgery, because of there's lots of reaction, and reaction cause fibrous tissue formation, and fibrous tissue helps to for this all the protection. So now I am taking little bit from inside also, some tissue to avoid any dead space formation. One more 20 I need. I am not putting any continuous suture at this level, because wound essence can happen, and to avoid the dead space formation I am putting all these interrupted sutures to make sure that healing happens better. We are going to keep a padded dressing for this case at least for 7 to 10 days in this area, so that we can keep a pressure on this area and avoid any fluid formation till the basic healing takes place. And we'll give local anesthetic. Full. 30 kg body weight, 3 ml. Can I change the needle? Now next suture line I am putting continuous suture. I am using again 20 PDS. What's the time?
1:40.
That cataract surgery cases come.
Yes, sir.
We have asked them to put the drops.
Yes, yes.
Nylon. So the rest of the suturing will be as usual suturing. We are just doing the interrupted skin sutures, and that's all about this surgery. So we'll keep uploading more and more video. Thank you.